those in our facilities, and from that have built some really cool tools. One of those being Scan to PCC, as I mentioned. When it comes to documentation in our facilities, it was always an extreme challenge to update resident records and point-click care. Led us to develop that tool. As I mentioned, we've been sharing that with others. You guys are now using that in your facilities and seeing a lot of progress and efficiency there as well. So we met Chris a couple years back, and he came to us with this solution for Triple Check. And in our facility, as I'm sure as yours, you guys understand how challenging this process can be. It required hours and hours of meetings from our teams. It led to just numerous human errors across the board, and which ultimately led to a bunch of failed claims, and just very challenging to work through that process. So Chris worked really closely with our team and our specialists in our buildings to develop this application, and it's been very impactful for us. Those meetings that were hours upon hours a day are now down to about 15 minutes, and has just continued to, like I said, improve over time. And we're really leaning into our trusted partners, in working with you guys in Scan to PCC. We're trying to just receive as much feedback as possible, and would love to just answer any questions you guys have on this, but ultimately just trying to get some really solid feedback from our trusted customers. But this is a very fantastic tool, and excited to introduce Chris here. He's the founder of Accuri, and we'll be walking you guys through the application today. So I'll go ahead and let Chris kick it off. I know we got a lot on the meeting, so I'm not sure if we want to do an intro across the board, but I assume that we have all the key decision makers here for Triple Check.
Awesome. Thanks, David. Yeah, I'm happy to go through. I can do a quick intro, and then if you guys don't mind, I'd love to know just who I'm talking to, different roles here at your organization. So I'll start. My name is Chris, as David mentioned. I'm the founder here at Accuri. I've spent the last 15 years building and operating software companies, specifically in that intersection of AI and compliance. And actually, before Accuri, I always like to tell the story because it's funny. I was actually working with a company that was building an AI solution for payers to handle contract configuration. So essentially, we were building software that would help payers deny claims. And sort of after seeing the seedy underbelly, so to speak, of the payer ecosystem of software, it's sort of what led me to build Accuri. So I decided, after seeing the way that the payers were purposefully trying to develop AI to deny residents or patients care, I wanted to build some software that would help sort of combat that level of automation that the payers were introducing. And so that's why I built Accuri, was to help automate and improve the compliance and automation posture for skilled nursing facilities, so you guys can more quickly, more predictably bill your claims without worrying about payer denials or RAC audits or any of these kind of issues. So I'd love to know just who I'm speaking with, who's on the call, if you guys don't mind going around and doing just a quick introduction.
Sure. I'm Robin Dunlap. I'm the Revenue Cycle Training and Compliance Manager at your service.
Awesome.
I'm Angela Takanashi. I'm the AR Manager for the South.
Erica Gonzalez, AR Manager for the North region. Pleasure to meet you all.
I'm Valerie Roscoe. I'm the Director of Revenue Cycle Management.
I'm Sneha Patel. I oversee the IT for Generations.
I'm Dan Head, Director of Therapy Services.
Records Consult.
Awesome. Well, thank you all. I heard North and South. I don't know if East and West were unavailable today, or if you guys just have the North and South roles.
We just have North and South.
Okay, all right.
I was going to say East and West, they're under a house.
But thanks for the suggestion. We'll throw it out to the universe. No.
Oh, that's funny. Well, I'd love to kind of just jump in here and set the stage with a number that should concern all of us. CMS tells us that around 97% of payment denials come down to documentation gaps, not clinical issues or care issues, just actual missing documentation or undocumented issues in the claims. And almost every time I've met with a new prospective client, I've seen this play out in real time. Everyone has some sort of a process. They have a checklist. You've got really smart people working in your facilities, good AR folks who have good intentions, but anytime you have humans driving this sort of a checklist spreadsheet process, you have a point of weakness. And it's not a criticism of any organization or person. It's just human nature. Humans are fallible, and we're always going to overlook small details. And so what we did was we really studied, what are those weaknesses and where do they live? And we found two large intervention points that we wanted to focus on to start. The first being validating the claims before they go out the door. So everything you do today with your triple check automation or your triple check process, doing the spreadsheet or whatever you have, we wanted to automate that fully and validate that claim from, top to bottom before it gets billed. And then the second we found is actually monitoring for changes after billing and maintaining a documented audit trail that you can actually use to prove to an auditor that you did what you say you're doing. So this is where we focus. We don't want to boil the ocean. We're really just addressing these really core areas that we see that humans can cause errors and create a lot of exposure. And so I'm just curious how you guys do your triple check today. I'm sure someone in the room is familiar or owns that process. What do you guys do today in your facilities when you go through your triple check?
Robin, do you want to take it?
So we have a checklist. Basically, all the department heads that are involved, medical records, MDS, the director of rehab, and usually a nurse, gather once a month with the checklist that runs down the claim details, and it makes sure that the diagnosis codes are accurate, the MDS has been sent and received, that the HIPS code is correct or the level is correct. We have an authorization. We have a signed cert from the physician. Basically, it's a very manual checklist right now.
Okay. Well, that sounds very familiar. I honestly haven't talked to a single organization that does anything any differently. And yeah. I think, there wasn't any solution for this before. So everyone's doing these checklists. And here's what I hear, for the most part, when I sit down with organizations and talk through this, is that almost every leadership team that I talk with has some level of concern that, their process is not being done correctly, or in some cases, whether or not it's being done at all, or if people are just signing off and saying they completed it. A lot of times you have good people, good intentions, but there's this nagging feeling that something's getting, slipping through the cracks. You're worried about a future RAC audit, whether you have defensible revenue or not. And in our view, it's perfectly reasonable for, leadership to feel this way. There is a difference in, being able to trust your process and being able to prove that your process is being done. Very different things. This gap isn't anyone's fault. Every organization that has these checklists, it's just that there's literally been no technical solution to automate this until we built Accuray. And so, in your case, you're trusting that someone is performing the checklist, reviewing the data, not missing things with 26 facilities, each doing things, their own small way, their own checklist, maybe small process differences. Those little gaps multiply into pretty significant legal and financial risk. And just, what I can tell you from my own personal experience working with different organizations of all sizes, for every single audit that I've sat in where we're running our software side by side with the current manual process, we have found an issue that a human missed during their manual review every single time. And these aren't little things, these are things that will fail an audit if they occur, or these are things that will cause a clawback or even a denial if it's submitted incorrectly. And so these are just issues that humans will always miss, regardless of how many checklists you have, how many spreadsheets exist. It's just human nature to overlook some of these small details. And so here's what we really are here to talk about, and we're here to help you guys improve patient outcomes and build more defensible revenue. That's our sole goal. The reality is that triple check, the way it's done today, it takes up an enormous amount of time from your most valuable people. You guys mentioned nurses. Nurses filling out a spreadsheet like this is not the best use of a nurse's time. I think most of us probably agree on that. It's not about improving patient outcomes. It's not generating revenue. nobody questions that you need to do it, these checklists or these end of month audits. It's just the way that it's done is not ideal. And what Accuri actually does is address that opportunity cost. We create the accuracy, the efficiency layer so that your people can spend their time on work that really moves the needle, improving patient outcomes, generating revenue, doing things that really is focusing on your business. And we handle, we replace these 2-day meetings that you do every month, reading data off a checklist with an automation that handles it for you. This is a slide, just the financial reality of some of this is always interesting to me. These numbers are pretty conservative. So what I've done here is I've taken your, I think, 26 skilled nursing facilities. Is that correct for you guys?
Yeah, I think 26 SNFs.
Somewhere around there. I took the number for 26 facilities and basically assumed 35 Medicare claims per month per facility. Really conservative. I'm sure some facilities are doing 100, some could be doing 10, but somewhere in the middle there, we're going to hit 35.
22.
22. Okay, so this might be a little higher, but somewhere in the same ballpark. So assuming 35 Part A claims per month across 26 buildings in this model, you're looking at roughly 910 claims a month. So give or take, 100 claims, we'll say 800 claims with 22. I then apply just a really conservative $15,000 bill per Medicare stay, which is also on the lower end of what you'll bill for most Medicare claims. Even at these conservative numbers, you're still looking at almost $13 million a month in Medicare billings and Medicare claim volume. And, we know that CMS tells us that there's around a 14.9% error rate industry-wide for Medicare Part A claims. This means that across all Medicare claims that are billed, almost 15% of them have some issue that results in a claim denial. And I'm sure you guys aren't seeing 15% of all your claims being denied. That would be pretty crazy. But, assuming you guys are 10 times better than the industry average, so let's just say 1% of your claims are being denied across your entire organization, you're still looking at almost $130,000 a month in risk, in billing risk that could be clawed back or denied, resubmitted, delayed. I mean, it's a significant amount of money. And at this volume, when we find just 1 or 2 issues, 2 or 3 claims per month that, you may have otherwise overlooked, we pay for ourselves. And that's not including, the amount of time that your nurses, billers, and administrators get back every month as well. What we've seen with our software is that if you say you take a 4-hour triple check on day 1 and a 4-hour triple check on day 2 after all the MDS has been submitted the next week, you're looking at 8 hours a month of this multidisciplinary team spending on the triple check. With our software, what we see is that once we onboard people and ramp them up, we're seeing 15 minutes being spent on these audits. And that's only if there are issues. You could come in and everything's passing in green and you just bill and you spend no time at all on the review. And so here's the other side of this. Obviously, decentralizing authority and empowering your local leadership is obviously great for business. It helps with employee retention, leadership development. You guys can move quickly. And there's a lot of reasons that you should have that decentralized authority, that agility. However, Medicare triple check is not one of those areas. This is an area where consistency absolutely matters. And when CMS comes, they don't care that you have one building that has a good process and follows that process and another building doesn't. They only care, what the gaps are. They care that every claim at every facility was validated, meeting CMS and OIG expectations, and it's done the same way every time, every month. And so Accuri evaluates 100% of your Medicare claims against a standardized rule set. We've built this rule set working with, hundreds of facilities. Every validation gets a timestamp, it gets an approver, a data source, proof of completion, the same rules, the same standard every time across all of your facilities. And that's sort of the way that we operate here. And so here's what it looks like today. We'll think of Accuri as an independent verification layer that sits between your clinical documentation and your billing system. So before a claim actually goes out the door and gets billed, we validate that every required piece of documentation is actually in place and that it is meeting the expectations we have for each of those checks. So what used to be a manual review happening behind closed doors becomes a repeatable, auditable process with completion metrics, visibility, dashboards. You get to see the whole scope of each of your facilities' completion. And this is how it works. We partner with PointClickCare. We're both a marketplace partner, but we also integrate with Data Relay. That's sort of our main integration point. We pull data directly from PCC into our system, and our rules engine evaluates every claim for billing readiness in real time. And so we pull from census, we pull all residents that meet the Medicare A, payer status. We're also supporting managed care in Part B here in the coming months, but today main focus is Med A. And we pull those claims into our system, and we start immediately evaluating them for readiness. We look at all the things you would normally look at, demographic, name, and I'll go through the software here in a minute and show you what it looks like. But we look for all the things you would normally check, and we're doing it in real time throughout the month as soon as those residents exist. And so what this means in practice is that your team's time is totally transformed. Instead of going claim by claim through a manual triple check each month, your people, you really focus on the claims that our system has flagged, claims with issues. Maybe there's a MBI issue and eligibility doesn't run, or maybe we found an MSP and you want to make sure that you can bill that claim because the MSP is open. Whatever it is, we really focus the things that need, actual human attention. And so in our world, with Accuray, you show up to a triple check meeting at the end of the month, and 99% of the things that you were doing manually previously are already complete, and you're really just focusing on things that have issues. And so with that, I'll actually hop over to the software. And if at any time you guys have any questions while I'm going through this, don't hesitate to interrupt me, ask questions. I'm happy for this to be interactive. So this is sort of the main view when you log in. We have a dashboard. This will show you all the facilities in your organization. You have a view of exactly what was done. This is for April, so we can kind of see that most of the triple check has been done for April. A few things are still being reviewed. Maybe MDS is late or whatever it is. You get to see per facility how your facilities are doing, how they're completing things. You get to see here sort of the top issues across your facilities. So if there's a failing rule, you get to see kind of what the most common reason for rule failure is. In this case, it looks like CERT failures or MBI mismatches. You get to see when we run our eligibility checks, if there's any issues with eligibility runs, and then sort of some other statistics on what's being done within each facility. But I'll kind of hop over here to claims. This is really the main view. This is where the boots on the ground will spend most of their time during the actual triple check. And here we can see if I filter for April, I guess first everyone can see the screen okay, right? Everyone can read this just before I keep going into this. Just want to make sure this is readable.
Yeah.
Okay, great.
Yeah, I got you.
Cool. So this is the kind of the main view that you'll generally spend most of your time on. You'll hop into the claims view. You'll filter down by month. So if you're doing the April triple check, you'll say April 26. Usually what you'll do now is just click on failing, and you'll just see the failing claims that really need your attention for this month. And there's a number of reasons that claims can fail, and we'll kind of go into some of those, but I'll show you now sort of what this view looks like. So once we've filtered down to the claims that need our attention, we click on the resident, and we actually get this view of the resident for the claim, for their billing period and stay, and we get to actually see exactly what's being evaluated for this claim. We filter at the top the reasons the claim is failing, and so in this case, we can see that we're missing 1 day of daily skilled documentation. And so obviously this isn't something you can fix retroactively. So when we flag these type of failures, really the outcome we expect is that there's a training or process improvement so that the next month you don't have similar gaps. Similarly, we can see that the FA UDA and GG admission UDA were both done late. And so we can see that they were done after the 3-day requirement for both of these UDAs, or 5-day in the functional assessment UDA case. And so we flag these and say, hey, it looks like your UDAs aren't being done timely. And again, this is an opportunity for training and process improvements across your org. But if you get audited, these things are, these are reasons that you'll have claim denials or delays. So we want to make sure that those processes improve. We do have 2 things we ask that are manual. These are things we can't automate. And so we just ask if a non-knocker is required for this stay. You just say yes or no. And then we ask if an ABM is required. And so if you say yes, it'll add another little box here that you'll say if a non-knock was issued and signed. And so you just have this one little manual step for each resident to make sure that the non-knock flow is done. Everything else below this is fully automated. Oh, I see a hand up, Robin. What question do you have?
I was wondering if you would, in the future, be able to scrub the miscellaneous documents for the non-knock and the ABN.
When you say scrub, do you mean just look to make sure that they're signed and that they are issued, or?
Yeah, like if we had a naming convention non-knock or SNF ABN, if you guys could pull that to view to see if they were completed.
Yeah, and so because you guys are a Scan2 customer, it's even easier. We integrate with Scan2, and we can basically say, send us all documents that you send through Scan2 to us, and then we can run those documents through our AI layer. And so when you answer this question and say a NOMNOC is required, we can actually now look for that document and do an analysis of it to make sure it's signed, it was issued, the dates are correct, everything you tell us that you want us to look for, we can very easily build a rule. And with that, I'll also note, a lot of what we do is sort of do some customizations of the software. So we've built this rule, this list of rules out of sort of the industry best practices that we've determined. But for exactly that type of situation you asked about, Robin, our next step after this demo is really to work with you to understand what your current workflow looks like what you do for your triple checks. We map that against our rule set. Usually there's one or two small things that we want to add. Maybe you have a custom UDA, or maybe you want us to look at the NOMNOC like you just described if you're a Scan2 customer, and we add those little customizations for you. So we really aim to fully, be one-to-one with exactly what your current triple check process is. But then we also layer on all the other things that we automate that we've learned from industry standard or industry, the industry, that these are other things you should also include in your triple check process. So you sort of inherit the whole best practices that we learn from everyone else that's, operating a SNF in the country. But to answer your question directly, we can absolutely scrub those documents, especially because you're a Scan2 customer. It's even easier for us. And so we can kind of see, these are what failures look like. We have a couple different categories of rules. So you can see this info. These are rules that these will never fail. These will never block a claim. But these are things that, we just document because it's something that CMS likes to see documented. So admitting diagnosis, the CMG breakdown, we just document this here cleanly. So you have one view for a lot of these things. So if you get audited, you can export this whole page with all the things that are documented. So you have that whole audit ready sort of package. And so a lot of these info rules, these aren't really things that will hold up a claim or fail. They're just more in the event that you want to, double check and make sure that there's nothing unexpected if you want to review it. But everything else here where we see pass, these are things that actually can flip and fail. So depending on the logic that the rule defines the rule, and then the data points that we see from your point click share system, these can actually fail. So for example, 5-day MDS ARD timing window. So if we see that the MDS wasn't completed timely, this will fail, and you'll have to address it. If we see that the admit date doesn't match what we see on the UB and what we see in MDS, this rule will fail. And so all of these rules sort of have logic like that. We make sure the ARD that's being billed matches the ARD and MDS. If we see multiple assessments, we actually look to see, is there an IPA that's open and unlocked that's not being billed? And we flag that for you. So we see that there's an assessment that's an IPA for this stay and it's not locked. So you don't want to bill yet because you want to get that IPA in and get it locked. So we flag those type of things. Similarly, if we see that an IPA is being billed, but there's no corresponding assessment, we'll flag that as well. So we kind of do both of the directional checks for the assessments that we expect to see. We do a lot of UDAs, so we look for a lot of different UDAs, BIMs, functional assessments, GG admission. We have customers that do certs as UDAs, and so we support that wherever it's relevant. Lots and lots of UDAs. Pretty much anything you have as UDA, we can build automation for to ensure that it's completed or timely or matches some other data source. Whatever you guys need is pretty easy for us to customize. We do look for cert research. So this particular customer, they have an actual paper cert that's wet signed. And so this flows to us from Scan2. The cert's uploaded into our system, and we look for a number of things. So we check that the name matches what we see in eligibility. And so we can see here that the name was verified as correct. We look for a couple things like, is there a physician signature present? If we see PTO, T, or ST, we look for a matching UB. So in this case, we see that there was PTO, T, and ST on the cert, which means that it's going to trigger us to look in the UB. And you can see here that we see the cert had the 3 and the UB had the 3. So we see a match and we pass. If any of these are not matching, the rule will fail, and you'll have to go look and try and figure out what's going on. The way our system works in a failure scenario like that is that depending on the type of failure, all you need to do is address the issue. So if you issue a new cert, you just re-upload it. We immediately pull the cert in and we start doing the evaluation. If it's maybe that the UB is missing the therapies that the cert documents, you just need to regenerate the claim and it'll flow into our system. So a lot of these things are they're all fixed in point click here and they flow through to us. So it's not really deviating from your current workflows. You just follow the standard as normal. We just flag it for you to review. And then once you fix it, our software updates and the rule immediately starts passing. For some things like these skilled, go ahead, Robin.
Sorry, while we're on the topic of certs,
yeah.
We're talking about possibly doing away with our paper certs and going directly to template certs orders in PCC. Would you be able to pull from those? I'm assuming everyone has their nuances, and you said you can configure, kind of specialized configure. Is that something you can do for certs as well?
Absolutely. And most of our customers are not doing paper certs. They're doing the
Yeah.
EDAs or the PCC templates. So we do support both. And I do suggest you go that direction, because one issue we often see with certs is that they're completely illegible. You know, the physician
Yep.
has handwriting that you can't read. And so obviously AI will fail, and then you have to go manually review it, which is never great. So moving to the electronic certs really helps with some of this, automation and consistency.
Very good. Thank you.
The one thing I was going to note, so let's say you have a rule that's failing, like this daily skilled need. This isn't something you can go fix, right? Like, this is, you missed a day for your daily skill documentation. That's just it. You know that you missed that day. So this means how do you get this rule from failing to passing? So we have these override capabilities. And so if you're an administrator, if you're a nurse or a BOM, you can sort of come in, and as you're reviewing the claim, if you see that, oh, we missed a daily skill, all you do is you put a note in here and say, acknowledge, we'll update training for next month. And then you click apply override. And as soon as you do this, this rule will go from failing to passing. It documents the override reason, so we can see, exactly what was done. ACK improved training. And then I'll just click override, and you can kind of see exactly what it looks like here. We get this nice track record that says I overrode this with this comment on this day. So you get this full visibility into, what's being done and by who within the system. So there's no sort of behind closed doors things that you can't track. We also have, let me see, a couple other rules I just wanted to show here. So we do HIPS code matching. So if we see the HIPS code on the MDS doesn't match what's on the UB, we'll flag it. Similarly, we look for IPAs. If we see several HIPS codes, we look for several corresponding assessments. We do all the demographic stuff. We actually run our own eligibility checks for each resident. So as soon as we see a UB generated in our system, we'll run an eligibility check with our clearinghouse. And we use that data as our source of truth to electronically compare, the date of birth, the name, the gender, all of that information we check for. We check for MSP, we check for qualifying hospital stay, and all of that gets evaluated in various rules here in our system. MBI here, you can see we look for MDS being transmitted and accepted. Here's MSP. Here's another good one. So we look for any diagnosis codes that are in MDS that maybe aren't being billed on the claim. So if we see like, a diagnosis code that was sequenced, but for some reason, or was in MDS, but for some reason didn't get sequenced into the diagnosis sheet, which means it's not being billed, we'll flag that for you, because it's a good chance that you want to resequence the diagnosis and get that NTA in there to increase your revenue. And so we flag all of that for you if we see any of those. And similarly, if we see something being billed for that we don't see a matching diagnosis for in MDS or therapy, we flag that as well. So sort of both directions will let you know if there's a discrepancy. Go ahead, Robin.
Are you looking for diagnosis codes on the MDS or diagnosis codes entered in the primary diagnosis sheet? Because those will always match what's on the UB.
So yeah, we compare all of them. And so we compare the MDS against the diagnosis sheet and against the
Okay.
UB. We don't compare, and we actually do compare, the UB against the diagnosis codes, because what can happen is the claim gets generated, and then someone resequences the diagnoses, and now you have a mismatch. And if the claim doesn't get regenerated, you could bill a claim that maybe is mismatching what the diagnosis has. So we flag all of those things. Chances are, your biller will see that before they bill, and they'll fix it. But we make it very predictable so that you always get that awareness that these things changed and that you should address it.
And the scan too, the qualifying hospital stay. I know you run eligibility on the common working file, but what if the qualifying hospital stay has not been billed by the hospital yet, which happens a lot?
Yep.
Is there any other source document that you pull QHSs from?
No other document. The only other thing we look for is if on the UB the biller has put the date, we make sure that that's entered, obviously, which is almost impossible to not do. But we don't check like an H&P or anything similar for qualifying hospital stay. We mostly check eligibility.
Okay.
but we can support other source documents as well if it goes through Scan2. So we would just need to map that out and talk through what you look for.
Well, I was thinking, like the hospital face sheets are usually uploaded by our admissions staff that comes from our referral source. And that's what we use in the business office to also verify that they were actually admitted inpatient instead of sitting observation for that period of time. So we do rely on the common working file, but a lot of times they're, fresh out of an exactly 3 midnight hospital stay and the hospital hasn't billed yet. So the only way we can verify that QHS is with with the hospital face sheet. And if they came in towards the end of the month, we're really, crossing our fingers, hoping and praying that the hospital face sheet was accurate, the one that was uploaded, and they don't, change it from observation or change it from inpatient to observation, and no one knew. So those end of the month ones are tricky. I just didn't know if you could pull from any other source.
Anything that goes through Scan2, we can pull from and do an analysis on. So if you have the face sheet uploaded through Scan2, we can definitely look at it and see if there's the correct or appropriate stay. Look for it if it's emergency room or if it's an admission or whatever it is. So we can define that and support basically anything that goes through Scan2.
And Scan2 is basically where we upload any outside documents to our miscellaneous documents tab.
Yeah,
that
so
goes through Scan2.
Yeah, so Scan2, instead of like putting it on your computer and uploading the PDF through PCC, you at your scanning your scanners, you scan the document, and then there's a list of categories, and you select the category, and right from the scanner, it sends it to PCC from that facility. And so when we partner with Scan2, we basically get a copy of it if you approve us to get that document, essentially, and then we would do that analysis automatically.
What if they came? So sorry, Chris. What if they came through electronically and we're just basically saving an outside source's PDF to a crap folder, if you will, and then we're uploading to PCC from that specific file we saved into, let's say, a downloads file? Does that go through Scan2?
I don't believe so. And also, uploads that go directly to PCC from your computer, we have no way of accessing. Point-click-care doesn't give any visibility for us to pull those documents in from their documents tab, for example. So the only way we'd really be able to pull any of these documents in is if they flow through the scanner and they flow through Scan2. David, I see you unmuted. I don't know if you had a comment as well.
Robin,
Yeah, I was
currently
gonna say
medical records is the one that is using it to upload the chart data in our buildings.
Okay. I'm just curious.
I was just gonna-
We have medical records on. Would a hospital face sheet be something that you guys would upload through Scan2?
No.
No.
Yes,
Okay.
we upload all the hospital records, but we need to make sure that all facilities are using the Scan2 instead of doing it with the PDF and on the computer.
Okay. Okay, thank you.
But would that involve, like, if you got documents electronically sent from a hospital, then you would have to print those out and scan them through for Scan2 to intercept them?
No, they can move the document into the folder. Medical records has a little folder that is set up on their machine. Is Scan2 PCC is picking documents from there, so they don't have to print. Yeah, they just move.
So it's not just accessed through a scanner.
Correct. Yeah.
I
So
mean, it can
if you
be.
received,
Yeah, you
if
can
you
put.
receive PDFs through an email or they're on your desktop, you can drag and drop those documents into the Scan to PCC dashboard and then upload them that way. So there is a way to capture it from the electronic side.
Correct.
Okay, great.
But currently, only medical records is set up to do all this function in our buildings.
Then I have a question. How is the MDS read? Because that's within PCC and not scanned.
Yeah, all the PCC
Right.
data we pull in from Data Relay. So we have programmatic access to everything you have in point-click-care. We have access to. The only thing we can't see is the Documents tab. For whatever reason, PCC doesn't give us any access to view that electronically.
Oh, okay.
So MDS, all this stuff, we pull in directly from PCC through the database that we set up.
Mary,
So
they're
just-
connecting through data relay.
Correct, yep.
The data relay does not keep the attachments in the file that we get from PCC. So the actual documents are not in data relay that these guys would need to scan. So that's why, that's the issue.
Yeah, that's right. And even further, we can't even see the index of documents that were uploaded. So we can't even see if a NOMNOC is present. They don't surface that information to us, which is unfortunate.
Yeah.
Sorry, go ahead.
No, those are done. Those are not done electronically, so those could be sent through Scan2 by medical records, since they're the gatekeepers of that. They could be the ones to upload the NOMNOCs. So we could have visibility on those.
Okay. Yeah, sounds good. Yeah, anything through Scan2 will come directly to us. We do also have, you can also upload directly to us. Although obviously we suggest is like these certs here we see, these came to us from Scan2. And so but if you wanted to, you can drag and drop or something. We just prefer it to be part of your existing process, so it's not an additional step. So we can see just a couple other rules. We do like therapy comparison, making sure what's being billed is consistent with what we see in therapy and PCC. And then, some other UDAs, physician care matching, the primary diagnosis is consistent. All of these things we're checking. We also do a number of like occurrence codes. So if we see, a specific discharge to hospice, we look for the correct occurrence codes being present on the claim, all sorts of these occurrence code matching depending on the discharge type, or if they're present, or if they've been transferred to hospice, whatever it is, we look for those things. Or if they're discharged from a hospital that's a partner, so their occurrence code 77, so they have, or the condition code 77, so they don't need a qualifying stay. We check for all of that kind of logic we look for and are aware of. One other feature I want to show, so we have this concept we call approvers, which basically is each facility can set up and define whatever approvers they choose to have. So you can have a biller, medical records, MDS, whatever. It's up to you guys to sort of define. You can have 1, you can have 5, whatever you want. You sort of define the approvers that you want. And what this means is that for each claim, at the end of the month, you still need someone to go in and click approve, basically, that saying like, I approve that this claim is ready for billing. And CMS requires something like this. They require some sort of attendance and sign-off sheet. So this is our version of that same concept, so that we still are meeting the standards that CMS has for this. So it's pretty quick. Once the claim is passing, you just click approve if you're an approver, and that's all there is to it. Let me see. I think that's the primary components I wanted to talk through. If you have multiple facilities, super easy to switch around. Any other questions I can answer on anything that I didn't address?
Me again.
Go ahead, Rob. I love the questions.
Oh, thanks. Okay, so you had said in the beginning that, first off, let me ask a technical question. So you said in the beginning the claims need to be generated first. So we have to generate trial claims. We don't have to put them in an edit submit batch, right? You're going to pull from trial claims.
So we don't actually need a claim to exist for us to create the resident in our system. So we look for our whole trigger is off of census. So as soon as we see census that matches, we create the claim in our system without a UV existing. What we do recommend is that you generate weekly trial claims. And as soon as we see that weekly trial claim, we pull it in, and then immediately it starts doing all that comparison. So once MDS is locked and the trial claim is in your weekly PPS meeting, you could be doing these reviews like just as part of that stand-up and addressing issues throughout the month, rather than waiting until the end of the month to find out that there was some problem you should have addressed 3 weeks ago. But we do have that dependency on just a trial claim existing. And every time you regenerate it, we pull the new claim into our system and we update that component. But the claims themselves are just one component of this entire sort of view here. So it's not the prerequisite for these claims existing. It's more of a data point that we require for these rules to pass.
I just wanted to make sure we could generate trial claims and we didn't have to move them to an edit submit batch before you guys scrubbed them. So that's awesome.
That's correct.
And then
just trial.
And then my second question is, you had mentioned that managed care and Medicare Part B were in the works. Do you have like a time frame for that?
So Part B, we're planning to launch June 1st. We have another customer that we're launching that with. That'll be the first sort of trial run of Part B with that customer, and then we plan it to be fully available in July. Managed care, we're starting shortly after. So I imagine managed care will be sort of end December timeline.
And were you thinking with your managed care, it might be too soon to ask, but were you thinking of like a level scrubber, if you will, like looking at medical records to determine if, you know, we're capturing the correct level based on contract information, or would you just be scrubbing a claim based on what we have in the system and what MDS has?
Yeah, that exact question is why I have managed care scheduled out to July, because if I'm being honest, I don't know the answer to that yet. My
Okay.
goal is to do the level scrubber, but I'm not quite clear on the complexity that will be involved yet, so I'm hesitant
Okay.
to commit. But that is my goal, is to have the level scrubber and the, because that's what I built actually before Curie, was automated contract configuration scrubbing for the payers. And so I'm pretty confident we can do the same on your side, but I'm just a few unknowns for me still that we'll address this summer.
Okay, cool. I'm done. Thank you so much.
Thanks, Robin. Just kidding. I have
I'm a
just
question hog.
one question. I know you're fine. I have one question, just because like when we all visualize this, we kind of go like, oh, okay, yeah, that makes sense. That makes sense. And sometimes we skip things that can come up, right? And so when you had other companies transition to this process, what sort of challenges or feedback on their behalf was received, just to kind of visualize what that looks like?
I think the single biggest challenge is just the change in process, right? Like it's change management.
Mhm.
And I think a lot of skilled nursing facilities struggle with moving from I'm doing everything on paper, I have all my documents, I know what I'm looking at, to this new sort of virtual way of doing it. I think that just that shift is a little bit of a challenge for people to conceptualize. And what I see is that
Fair.
most often, sort of the first month that they move to this, there's a little bit of friction. They're learning it. Maybe their review might be a little slow. But once people onboard and they see how it works and they understand it, I mean, it's like this, you know, downward curve of time spent on the
Yeah.
process. So I'd say that's probably the single biggest thing we've seen, is just getting people to learn and move to the platform.
Okay, appreciate it. Thank you.
And Mary, I see you have a hand raised as well.
I was just about to forget my question because I've been raising it for a while, Robin. I'm just kidding.
You gotta be faster than that, quicker than that, Mary.
You know us, Mary. You got to just get in.
I know, right?
Maybe I can jump in
one of
first. Okay. Go ahead.
I think one of my questions that I had was reporting. The reporting, is there like a way of analysis, like what's tracking and trending, what's what's missing, what are the common missing areas, so that we can actually create a work process to better, so that it's less missed?
Yeah, so our goal with the dashboard is exactly that, and we're still tuning this. We sort of released this about a month ago, this view, so we're still adding features every day, and we can always add things you guys want to see here specifically. But our goal with this is exactly what you described. We want to see, you know, for a given facility, what are the top issues this facility has? Like this facility had, you know, issues with these rules, and the override rule as well. This sort of indicates like how often is a user having to override a failure. And we see these guys had a lot of issues with the FAUDA, which means that they are not completing the FAUDA in a timely manner. And so this would indicate to me that we need a process change and some training to make sure that these are being done in the time required by CMS. And so that's our goal with this dashboard view, is to show you per facility or organizationally, you know, where your gaps might be and where you want to improve your processes, and sort of inform that improvement in process.
Okay, and then how is login? How do we manage it? Is it a single sign-on application? Is it a manual create a login?
So
Is it
today, oh, go ahead. I'm sorry.
is it affiliated with whoever has a PCC login or a scanned PCC login?
So today it's just a username and password. We don't have SSO quite yet. It is on our roadmap for the next 2 months to ship SAML and single sign-on. Who do you guys use for your SSO provider on your side? Your identity?
We're an O365 shop, so we do it.
But we have another customer that's asked for this, and so we're building it for them. And O365 is their provider as well, so we'll have support for that within, I'd say, the next 45 days.
What's the cost per facility?
So our pricing scales based on the number of facilities that we contract with, and so the highest tier we charge $399 per facility. If you're 10 or less facilities, that gets cheaper and cheaper the more facilities we engage with. So I can send you guys that pricing sheet over so you can get that full view after the call.
Okay, thank you.
So is it a fixed cost or is it
The fixed
by
cost, yeah.
patient? Okay.
No, I started with per resident cost, and it was far too complicated for us to try to line out. So we do a fixed cost per facility. I will say for Med A, we have this fixed cost. For Med B, because the volume is so much higher, we'll have basically an add-on cost from the core Med A pricing. And we still haven't quite finalized what we're going to do for that yet, but I can send you over our Med A pricing after the call.
Okay, go ahead, Dino. I have a few more questions, but Dino's been waiting patiently. So let him answer.
Thanks,
I get
Anna.
his question in, guys.
I know. Thanks. My name is Dino. I oversee the MDS and clinical reimbursement for Generations, and I apologize because I came in late, halfway through the presentation, but I have a couple of questions that may be stupid, or you may have already gone through this. But number one, for the cert forms, would this platform be able to identify, late signatures on the cert forms, or okay, it would be able to do that. Okay.
Yeah, we do that today. And I know you guys mentioned you might be moving electronic, but we do support paper certs or electronic certs,
Yeah.
and we look for late or missing information.
Okay, that's good. Thanks. The second thing is 90% of our denials from our ADR is because of the accuracy of the HIPS code. And I was wondering, I don't know if this is too technical for some people, but I was wondering if this would be able to identify inaccuracies of the HIPS code. Like, for example, the fourth character of the HIPS code, let me see, let me make it simpler. Like the third character of the HIPS code is for nursing. If that letter is letter C, it means isolation. So would this be able to identify based on what scrub or whatever, that if we code C for isolation, that this would flag it like, hey, your isolation is not being met by the criteria.
Yeah.
Would it be able to do that? Okay.
So it doesn't today, but we actually are building this by August. We have another customer we've contracted with who's requested this exact functionality. And to start with them, it's focused on RT and pulmonary and Med B billing. But the idea behind it is that we'll have an analysis that will look at CMG, HIPS codes, and also just generally supporting evidence for a claim. So it'll look through progress notes and any UDA notes that exist that we want to look at and sort of make a determination on do we have sufficient evidence to support the outcome of this claim, the diagnosis and the CMG and all that stuff. And so it is coming. It will have that, and we can work with you to better define what that looks like for your facility as well as we develop it.
Perfect. And I'm assuming even ARDs, right? If the ARD is off or what have you, it should like flag it as well, right?
We already do that one. Yeah, we have a lot of things we already checked today. Like we just
Thank
don't
you.
look for supporting evidence of diagnosis or HIPS code, but we do check, like, is the HIPS code consistent? Is the ARD consistent? All of these things are already part of the platform.
Thank you. My third, sorry, I have a list. This may be stupid, but this would still require us to do like a face-to-face meeting at least monthly for a triple check, right?
We suggest that people still do their triple check meetings because there's often claims that have issues that need some discussion. Almost always there's something that happens where there's a claim that maybe, we see all the time that claims get misdiagnosed, like there's a sequencing issue for the diagnosis that gets into the UB that then gets resequenced, and so we see a mismatch. Someone needs to go review it. So there's pretty often at least one or two reasons for you to meet face-to-face. Our goal is for that meeting to go from 6 hours to 15 minutes. And ideally, it's even addressed before the meeting, but we do still suggest you do that meeting just to address any issues in real time.
Okay, thanks. Lastly, this is being recorded, right? So are we able to get the recording for this? Because again, like I missed like half. Okay, thanks, David. Appreciate it. That's all. I'm done.
What is
I
the
have-
lag time? The lag time with your data relay verification, how live are we?
It's up to an hour is the delay, and that's a PCC limitation. So
Yeah.
basically every hour it's anywhere from 1 minute to 60 minutes, depending on where in the log shipping loop we are, but it's anywhere, up to an hour.
Okay.
It's a data relay. When we get the logs from data relay, then these guys, if they connect to our data relay, they can then get the data. So it's kind of set through PCC. So we get
So on the 30s.
multiple
On the-
times in a day, we get,
Every hour.
data from PCC.
Okay, thank you.
You're welcome. So I have a question on the product itself. I know I don't know how long it's been in the market. How many customers do you have? How long has people been using this from a day-to-day?
So we started development about a year ago, a year and a half ago or so. We launched the first version of the product in January, and we have today somewhere around 100 facilities with another 300 onboarding through the summer. So still pretty new, like formal launch in January, but we've got a lot of traction so far, and I'm happy to share case studies or referrals, anything like that you need.
So in our PCC to scan system, we have sometimes where even though the file goes into the folder that is scanning into PCC, it never makes it into scan to PCC. It just kind of disappears. It's a bug that I think we're still trying to play with. We still have a building that's constantly getting that. And I know they're working on it, but those instances, since you've been around, how has those been managed? Because we're struggling to just get the data into PCC, and we just we scan multiple times. They do that multiple times, thinking it was the error from a user side, right? So those are things that we are currently experiencing already, right? So how would your system handle those things, and what would we have to do?
Yeah, so we have 3 customers that have somewhere between 50 and 75 facilities that use Scan2. I can say that the number of missing documents we see is less than 5% per month from those facilities. So I think I don't have the technical background with Scan2. I don't work with them. We just partner with them. But my understanding from talking to Colin about this is most often the reason that happens is that the server that's running Scan2 isn't triggering the process in enough time. So basically, from what I understand, there's a server that you guys run that basically looks for an ACRON, scheduled job, these documents that need to be uploaded. And if that's not scheduled correctly, or if the server doesn't have enough capacity to run that process, they can be delayed or go missing. But I would say I would defer to Colin to work with you guys on that issue.
So I get that, but how will your system and those struck that 5%? How does your system make sure it follow? I'm trying to understand. Now I have a gap with the system. If we go this route, we'll have 2 people that will be missing that data. So kind of want to understand how your system works on that particular.
I see. Sorry, I misunderstood. Basically, it just percolates as a failing rule. And so for our side, if there's like if you look at the cert, for us, it'll just show that we don't have a cert, basically. And when you see that, you just check, do I actually have a cert? Was it signed? And then you override the rule. So it's pretty quick. Like it just shows up as missing information.
But there is a way for us to know, where the gaps are for.
Yes.
Okay, got it.
Oh yeah, yeah.
And then from the AI side of things, sorry, Dino, last question. What's that engine look like? What are you using? Claude, Gemini? Is it open source?
No. So yeah, we use AWS Bedrock, and we use Claude primarily. And we also use Gemini for some of our image analysis and other analysis. But I can give you a full kind of technical deep dive into some of that if you'd like. We've had to do a sort of an AI vendor questionnaire several times, so I'm happy to dig into that with you. We are SOC 2 compliant. I come from HITRUST and FedRAMP, so I've done a lot of the heavy compliance side of it, so that's a lot of my background. But we can definitely dig into it and chat through more specifically for any other questions you have on that.
And from a data perspective, right? Because today a lot of AI tools out there is very public. This is enclosed so that it stays within the environment and it isn't being shared with from a learning perspective.
Yeah, that's one of the reasons we chose to go with Bedrock, Amazon's Bedrock, because they host and process the data within AWS, and so it falls under all of Amazon's data protection guarantees. So there's no model training. It's all covered under HIPAA, HITRUST, FedRAMP. All of that is included.
Okay.
Whereas Anthropic directly, they don't give you any of those
I know it's
guarantees.
out in the cloud. I know. So that's
Yeah.
whenever we look at an AI tool, my heartbeat goes up because I kind of need to understand the back end. So
Yeah.
I appreciate that. All right.
And
That was my
I'm happy to, sorry, I was gonna say, I'm happy to dig deep on that with you as well. Any questions you have, we're an open book, so you and I
okay,
can.
sounds good. All right, I'm done. Do you know you're up?
Sorry, I lied. I have one last question. Do you guys have like a sandbox? And if you do, are you allowed to share it with us?
We don't have a sandbox just because the functionality of the system depends on data relay. We are working on building some sort of a replica of data relay with obfuscated information so we can provide that sandbox, but it's been a challenge to fully obfuscate PointClickCare's database. So I don't have an ETA on that, but we don't currently offer the sandbox. But for what we normally do is, after we wrap up this demo, we go through the workflow review and just make sure we have, parity on your rules. It's very fast and easy for us to onboard. We generally just give you access and you can see your own facilities in there as we're working through, MSAs and so the, obviously we need a BAA first, but as we get through some of the more contractual pieces, it's very easy for us to get you your own information stood up.
This one that you're sharing now, is this like a real center or is this like, it looks to me like a sandbox?
Yeah, so we have obfuscation layers for my own local data, but I don't have a customer-facing obfuscation layer that I can share. So I have a proxy that intercepts request traffic and obfuscates, but we don't have something comparable that I can offer to customers
So
today.
you don't have a test trial site or
We don't have a trial site, but the way our MSAs work, and we can, get into that as well more deeply, is you basically have 30-day guaranteed money back and then 90-day cancellation for any reason. So as we get going, it's, there's a lot of guarantees to make sure you guys are happy.
Have you done proof of concept with a client where we have this manual process, right, that we do today, and we check, give you 25, 30 of those processes, you put it through your system and see how the manual process compares with your product?
So we do we generally avoid free trials or anything like that. But we again, we can onboard you fully and get you a hand. What we've done with other customers is that we basically choose a subset of their facilities, so you're not risking your whole organization with this process change. So we'll pick 4 or 5 of your top performing facilities that have a really good triple check process. We onboard them fully into the system, and then we go through and do a very white glove first month with them, and then based on that feedback we decide on if we want to cancel at that point and get your money back, or if you want to continue with the rollout with the rest of the organization.
how long is the implementation process?
Once we get access to data relay, usually the biggest time blocker for us is getting the actual SFTP credentials and Redgate stuff, which I'm sure Sneha can get us pretty easily. It takes us just 24 hours to actually get it set up and get you onboarded.
And how often are you there for support during training?
Yeah, so I do training. So if let's say we chose 5 facilities for you guys, we would do probably 2 calls, one to introduce them to the software, kind of get them familiar with what it does and how it works. And then the week before triple check, we go through with the group of facilities and do a review. And then on triple check day, what I've done in the past, is actually have the facilities set up a Zoom, and I'll dial in and kind of switch between facilities and make sure that they have any questions answered, any support they need. We're there for that first go around to make sure that it's very easy and clear and they have the support that they need for that.
And then I'm gonna go back to Sneha's question on like the help. So we have great communication with David and with Oh my God, I'm forgetting his name. Chris? No, Sean. How would we like again troubleshoot? We have questions. Is there a who can we go to, or is it a live person, or is it a link that we just chat to?
Oh, well, it depends on what you need. I try to be available or have one of our support staff available for anything you need live, especially in those first, couple of facilities ramping up. We have support, ticketing system, obviously, like you would expect, and we go through and triage, respond to tickets. But we, anytime that, especially in the first month or two, anything you guys need, we make sure you have a dedicated human that you have access to work through any issues.
Well, great questions, guys. Great demo, I think. I know
Yeah,
we're over time.
Any other questions from anybody here?
I think we're good.
All right. Well, so
Thank
for
you.
I know we're over time, but for next steps, normally what we'll do is I'll send a follow-up email out to whoever appropriate. We'll get a quick 20-30 minute session scheduled probably next week where we go through your current checklist, your triple checks checklist, and we do a demo or a gap to see like, do we have all the right things? Are we missing anything? If we're missing it, we go quickly build it. And then we go through and go into the contracting discussions and everything from there. And Sneha, I'm happy as well to talk to you separately about any of the technical questions that you have on our side.
Yeah,
Chris-
I am going on PTO, so I'll have to do it once I get back. So sometime early June. I'll reach out.
Chris, would you be able to send any quotes or agreements to myself and Sneha?
Okay, sounds great. I can send the follow-up email and we can get the conversation started there.
Great.
Awesome. Well, thank you all
All right.
so much for your time. I really
Thank
appreciate
you.
all the great questions and look forward to chatting with you soon.
Thank you.
Thank you. Have a good day.
You
Bye-bye.
too.
Bye.